very good morning. My name is M.O. Dani Boy David from the Bachelor of Medical and Health Science program for OUM. And today I'll be doing my presentation regarding about the rapid sequence situations. Here we have two individual, or do I say two students that will be engaging for my presentation today. And for now, we will be starting our theory session. Now, when we speak about rapid sequence intubation, we always think about what are the engagement, what are the engagement that we should do when patient needed to intubate. Okay, when we say intubation, how do we know? Now, this is one of the video that I will be showing to you, and how an anesthetist bring an intubation towards the patient, where they put the endotracheal tube towards the vocal cord, and then let the patient ventilate by himself. Okay? Okay. When we think about what RSI, what is RSI? What is it? People call it, is it relative strength index? No. For us as a medical, it's called rapid sequence intubation. So the definition of RSI, it is a process of quickly creating the optimal condition you need for intubation. So as in the most simpler way is to quickly sedate and paralyze a patient who needs airway protection. Okay, that note is not from there, you can just write it. The key point is the simplest way, where we quickly sedate and paralyze a patient for airway protection. Okay, now for this, you will, when you learn about rapid sequence intubation in RSI, people will get confused. Is RSI intubation versus RSI induction the same? And the answer is yes. They are the same thing. It's just that the induction are the one that we start first. Then after that, it goes towards the intubation. There is a process when we do it. Okay. Okay. Now for the objective of our rapid sequence intubation. Our first objective that we'll be doing is the indication. Indication, it means which patient that needed to do. As you might know that some of you may not know the words of indication or indikasi in Malay, but indication, it means the one that needed the priority, that we needed to do that procedure to them. Okay? And the second, the objective is to describe the equipment, personnel, preparation and technique in regards to rapid sequence intubation. And what the equipment that we needed, what the preparation that we needed. It means preparation as in what equipment, what kind of patient that we need to prepare. Do we need to put 2 lines to the patient, or do we need the type of laryngoscope for this patient? What do we expect? That's what they meant by preparation. Now, the indication of RSI. The first thing of indication RSI, there are 3 main points for indication that we need to see first. First, failure to maintain or protect airway. Those who cannot maintain their own airway properly. Second, failure to oxygenate or ventilate. It means by breathing by themselves, they cannot protect themselves, they cannot ventilate, they have their ability to breathe have gone. That's what it means by failure to oxygenate or ventilate. And the third one, rapid deterioration. This one is quite common. We will see this kind of patient in every department, in every corner of medical situation. Sometimes you may see that patient stabilized. Maybe this patient just came for doing maybe throat swab, or came for maybe a cold, maybe for URTI symptom. Then suddenly your patient collapses. That is what it means by rapid deterioration. Your patient change condition from good to bad. Okay, now the first indication, failure to maintain or protect airway. How do we know the patient failed to protect or maintain the airway? That's why we will evaluate patient's ability first. The first ability is ability to speak. That is why when we ask the patient, Uncle, are you okay? Same thing as BLS. Uncle, are you okay? If he can still answer you, it means patient can still able to protect his airway. Second, ability to follow commands. You will ask the patient, uncle, please raise your hand. Please raise your hand. Can you hold my hand? What is your name? If he can answer that, it means the patient can still able to protect his airway. Okay? And the third one is the most obvious one, are they conscious? When we look at him, whether or not when we call him, if he's unconscious, now that is the one that we consider to intubate. But that doesn't mean all patient that needs to intubate, because some may have different issue. That doesn't mean when patient unconscious we need to intubate. Patient maybe have maybe DXT low, maybe blood pressure may be low. It's quite different. And the fourth one, able to tolerate secretion. It means patient able to swallow. Can swallow. If patient can how to say, can spit out their mucus or swallow their own mucus, it means the ability to maintain the airway is still present during that. Okay. Okay. That one is quite simple for us to ask. But in the guideline, the most standard guideline for us medical is based on these two, where we evaluate the level of consciousness. One is AVPU assessment, where we ask from each syllables forward. Awake is patient is awake. If patient is awake, we don't need to do anything. Verbal, it means patient may not be awake, but patient can still able to respond to us. Like for instance, uncle, please raise your hand. Same thing, can still. Pain, it means patient respond to pain stimulus. It means when we call, patient won't respond, but when we give stimulus, as in pinching, giving chest, pressure towards the sternum, and patient when they feel pain, it means they still respond to pain. Okay, and the fourth one is unresponsive. Unresponsive is the one that totally we cannot do anything, and that one immediately we consider our indication for intubation. Okay, and the second one, this is the most accurate one, because this one will be used in your everyday routine as a medical assistant, and that is GCS, or people call it Glasgow Coma Scale. Have you ever heard of it? First time, okay. You can Google it for more info regarding about that. But GCS score is Glasgow Coma Scale score, where we evaluate from eye opening, E, D, verbal response, where they have their own marks, and motor response. It means the strength, the motor movement, verbal, when we ask the patient, and eye. Can he open his eye normal? Can he react everything without no one calling him, or does he need someone to call him? Uncle, please open your eyes. Then he just engaged during that time. Okay. As an additional note, if patient less than 8 marks, because in here, if you calculated 6 marks, 5 marks, 4 marks, the total marks is 15. For a normal mark for all human is 15 out of 15. There's no such thing as 14 normal. No. 15 out of 15 is a normal one, full mark. But if patient could show a score of less than 8, where we evaluate less than 8, then we consider intubation. We know that patient cannot the ability for them to respond to us are normal. Okay. Now, example. Now the second one is failure to oxygenate or ventilate. This is the example. Failure to oxygenate or ventilate, where we can see from a congestive heart failure exacerbation, it means CHF. It means congestive. It means those that have problem with their heart, end stage, those that have long-term cardiac disease, or do I say heart disease? And most of them, when they have this kind of situation, they cannot, the ability for them to breathe, to oxygenate are normal, because there are no blood supply. No blood supply to pump, because the heart is broken. Like simple thing, you imagine your engine broken, you cannot push all the oil inside the machine of your engine of your car. It's the same concept. When your heart broken, how the hell the the heart can pump all the blood to the body. It's the same thing because all the blood is also going to the lungs. When the heart is broken, same thing with our lung. Okay. And the second one is asthma. Asthma exacerbation, those that have showing symptom like allergic, for instance, any allergy like dust allergy, food allergy, or maybe have a history of asthma from the family. When their lung tighten due to the asthma, it causes them to spasm, where they aren't able to breathe as normal. It's the same thing. Have you ever seen any asthma patient before?
Yeah.
Same thing. It's the same thing, because the moment when patient cannot breathe, then we consider our indication for intubation, the rapid sequence part. Okay. Now, we know the examples of patients that fail to oxygenate and ventilate. How do we evaluate patient's ability to oxygenate? That's the question. Now, the first one, we assess their breathing level. Are they normal breathing, or are they breathing fast, or in medical term, breathing fast as in tachypneic or bradypnea? It means patient breathe a very slow breathing, but you must remember that sometimes an athlete patient is not like any normal patient, because an athlete, their breathing are much more better compared to any other. That is why we need to consider the physical as well as their history. What do they do in their life? Okay. And second one, listen to lung. It means we took our stethoscope, we listen. Have you learned about the use of stethoscope? Or okay. In listen to lung, it's the same concept. We use ITTA. We inspect the patient's lung, we palpate, we percuss, and we auscultate. Auscultate is the one that we hear whether or not patient have normal air entry or patient have bronchial spasm. You will learn more this when you get to that one point. Okay. So for now, you need to understand that when we evaluate by assessing the breathing and listen to their lung. The third one, where we usually do, other than looking at the feature of the clinical, is by using our equipment, medical equipment, where we see from the chest X-ray whether or not the chest show normal. Is it normal? Does it have any haziness? Or if any changes or abnormality of chest X-ray, we maybe see patient have pneumonia, patient have tuberculosis. Sometimes they will show abnormality towards the chest X-ray. Okay. Second one is pulse oximetry. Pulse oximetry is the very good equipment because it shows how the oxygen level of our body, oxygen gas in our body. In normal one, regardless is saturation, or people call it SpO2, is always more than 99 or 100, 99% or 100. They will never be less than that. If less than that, we must consider that patient may have an issue or problem. Okay. Arterial blood gases, where we took from our artery, and this one is considered a radial artery, where we took a needle, a syringe, we poke, we syringe out a few bloods so that we can see whether or not the arterial blood gases in his body, is it normal, or does he have respiratory acidosis, respiratory alkalosis. But this one you don't need to know much for now, because you learn this more for your next SEM or for your next year. But you will learn about this. Okay. But for now, at least you know what the indication, how we evaluate normal for patient, evaluate patient's ability to oxygenate or ventilate. Okay. For the next one. Now, the third indication is rapid deterioration. Rapid deterioration, it means, as I said before, patient change condition. From patient very active, then suddenly collapse. Doesn't know anything, then suddenly patient collapse. Okay? And the most example first is drug overdose. Drug overdose is those, like any other patient that may have taken much more higher drug like opiates, any drug abuse patient, because you will never know this type of patient when you see them by themselves. But sometimes when this patient came to your emergency department or your clinic setting, sometimes you don't know because you see the patient, he or she looks normal. Then suddenly patient collapse. Then we found out that the history, patient abuse of drugs, any drugs. Most of the time, the most common is methamphetamine, marijuana, but most of the time marijuana won't cost that much. But irregardless, the one that most common, especially here in Sabah, is methamphetamine. Okay. Okay. And the second one is polytrauma, or do I say those trauma that involve hemodynamic stability, where patient change condition due to their unstable of hemodynamic. It means hemodynamic as if their blood circulation in their body are disrupted. And when I say polytrauma, it means more than one organ. Instead of skeletal system, it may affect towards the integumentary system, towards our GI system, all of it. Patient may came, suddenly patient have broken arm, then found out patient have a lung contusion or liver injury, so forth. That is what it means by liver injury. That is what it means by polytrauma. It means more than one system of our body affected. And this thing from our side, from drug overdose polytrauma, sometimes patient can show that they're very alert, they're awake. Alert as in they're doing as normal. Like I said, very good. They can answer your question. They awake as in yes, they awake. They are not unconscious. They speak as normal and they can protect their airway. It means they can still breathe by themselves. They can still protect everything. But sometimes that's the thing. A rapid deterioration. From these three, patient can suddenly change to a rapid clinical deterioration. Patient change condition, like I said. And then patient will lose their ability to protect their airway. Okay? Now, for the general summary of indication, RSI is the step a clinician, or do I say us? Clinician, it involves to all medical staff, regardless you're nurses or medical assistant or a doctor, even for any like normal one, PPK or anything, because sometimes they would need to learn because they are an essential medical staff as well. And part here is the steps a clinician takes to rapidly secure an airway involving the use of medication to sedate and paralyze the patient. Sedate and paralyze we will learn for our practical session. What do we need to know regarding about this? And the patient, in order to create the perfect condition for intubation. That's the thing. When we know what's the indication, which patient we can target for our RSI, then we can do our part to secure, or do I say to create the perfect environment for us to intubate the patient, or do I say putting an endotracheal tube towards the patient vocal cord, trachea, so that we can ventilate in as normal. Okay. Now, for the next one, or do I say the second objective, equipment, personnel preparation of rapid second intubation. This will be explained more with our clinical session. Okay? And this will be continued in our clinical session. Okay, thank you. Look it by yourself.
During the practical session, I explained the guidelines of RSI, which is the 7 P's, where I provide information regarding how to describe the equipment, major roles of personnel, and preparation efficiently. However, during the recording, there are few technical issues that hinder my video, in which I apologize. That is why I'll be focusing on to the main part of the practical at that time.
The fifth phase of 7 P's of rapid sequence intubation is the positioning. The positioning involves bringing the axis of the mouth, this is the first position that we will do, and larynx into alignment, leading to what's called the sniffing position. This is one example of snipping position. For example, if it's a patient with lying flat, it's called a supine position. But for us to achieve that level, or do I say the level of access between the mouth, pharynx, and larynx, we will put one pillow, a non-softened pillow, to elevate so that it makes an axilla between it. The level where we can, to make it easy for us to intubate the patient. That's the simplest way to explain it. This is the example, the positioning that we are targeted for the patient. The level, as you can see from my slide here, the sleeping position attained by putting 10 centimeters a non-compressive pillow. This is one example of non-compressive pillow. And another one, when we provided, as I said it before, we need one assistant from here. Okay, don't worry, just come. We showed the positioning of the next one phase when we do rapid sequence intubation is the cricoid pressure. Cricoid pressure, or people call it a Selig maneuver. It may be used to occlude the esophagus with the goal of preventing aspiration. Because when we give muscle relaxation to the patient, all of the patient's ability to breathe, it's not about the breathing as well, but its peristalsis will not be working. And patient that we don't know about the history of its meal, last meal, sometimes all the food projectile or any food substance will come out from the mouth due to us giving the muscle relaxant. That is why when it is required for us to do this Selig maneuver to prevent aspiration. And this one example of positioning that we do. First, we find the landmark. We know from this landmark, as you can see from here, this is the cricoid cartilage. We will ask our assistant to provide cricoid pressure. So we ask him, from this level, we will ask for him to compress, to do the cricoid pressure or Selig maneuver. You can do it from here. It's okay. No, here. On this side, do this one hand. Compress, giving a pressure. Okay. No need to go hard, just relax. Okay. This is one of the example. Okay. Relax, just relax. Now, the placement of proof. Now, as I am showing you right now, this is for the 6th phase where the intubation occurs. Now, I'll be showing you how the intubation works in real situation. Now, when we do it, we must make sure that all the sets are ready. For example, our stethoscope, our airway, as we already calculated here, our back valve mask, just in case we need to give a pre-oxygenation to another extract of pre-oxygenation to the patient desaturate. Certain places may have the back valve mask for anesthesia department. They will have a GA machine. For instance, this is one of the examples of Excel, where we have one person to provide ventilation from here to here. We ask him. And after the giving of the fasciculation, after the fasciculation end of 45 to 60 seconds, it's crucial that one of your assistants maintain the cricoid pressure in that 45 seconds to 60 seconds. We provide this. Cricoid pressure. Okay. When we prepare everything already, now, side notes, when we do this, it's important that the level of our bed is the level of our hips. Because if we do it in a uncomfortable position, it may give much more, a long-term backache to us, especially during this intubation. So when we provide it, we must always do it. We must make sure our assistant will be on our side. This is our blade. I'll be using size blade 4 for now. It has the various size, like blade 3 for smaller adult, blade 2 for any children or pediatric. Now, when we provide it, after the Selig maneuver, this is our sniffing position. We will do a bit jaw thrust, head tilt chin lift to the patient. We do swiping of the tongue. as we do it, you see it. When we do it, for instance, like this, we ask our staff to manipulate, our assistant to be example. Okay, for instance, he can provide it. Maybe his site might be difficult. We can ask for another assistant. Come, we can provide this. It's okay. Come, it is way on this. Okay, good. And one of our assistants will give us the key. Come, give me the key. Okay. For example, this is one example that we'll be doing the placement of it. Okay, then after that we ask our assistant to pull out the stellate. Okay, and we'll push the tube inside. Then after the placement, we'll pull out our blade and make sure. Then after that, during our system giving cricoid pressure, it's important that after that, as a leader, we will say, okay, cricoid release. Release the cricoid to the patient. Then after that, the next step that to make sure that we can ventilate, our assistant will give pressure towards the cuff, for instance. For now, I'm only giving it as an example how we do. Give pressure towards it. Then after that, for now we'll be using this back valve mask to provide it. We ask our assistant to hold it. Come. Ventilate it. Bend it. Okay. This is the example that we'll be doing. Unfortunately, we will not be able to see the lung directly because this is just a mannequin. That is why we will go to the sixth phase, that is the placement of proof. In new standard, especially nowadays, the placement of proof, the gold standards for verification of proper endotracheal tube placement, it means is the tube went to the lung properly or went to the stomach. Is by using this medical equipment that we use nowadays is capnograph, where we see the presence of waveform capnography. This is the example where we show in our machine that is supposed to show the presence of waveform. If we can ventilate it with our machine, where we connect to a machine of capnometer, and it shows a reading of capnograph and constant level of end-tidal CO2, it means the placement is correct. It is going to the lung. To explain it more, it will be more difficult, but for now, we at least to know that the gold standard is based on waveform capnography. And the second one is okay, continue. Now continue bending. The additional verification is based on these three that usually we will look at it. First, the air vapor in endotracheal tube. It means here. Unfortunately, because this is not a live patient, we will not be able to see it. This is just a mannequin. The auscultation, where we will be auscultating by ourselves. Check from here. Check. Reading. Okay. We will ask our assistant. Okay. Reading. In certain cases as well, we can see whether or not our placement is correct with the presence of chest rise. It's not like we can see now is the lung or anything, but in a real situation, you will see the patient chest will be moving up and down. Now, the last phase, that will be the post-intubation management. The post-intubation management is crucial that after the proof of placement, anchoring of the intratracheal tube should be a priority to prevent dislodge. It means we must make sure the placement is correct. At the same time, it must be fixed. So as I showed before, the endotracheal tube tape, when continue begging as we, just like any normal one, where we anchor it like a real patient. There's a different technique in all cases, but so far I will be showing you how the technique goes in our anesthesia department, in my workplace. If we put this, it will be more easier for us to ventilate it without worrying the tube to go dislodge. Okay. This is one of the example of post-intubation management that will be done after that. And for instance, in certain in certain cases, like for instance in the operating room, it's crucial that we close the eyes as well to prevent any foreign body to go into the patient's eyes. In the long term, or in any cases that involves with using any harmful substance that may affect towards the eyes. It's just an example. And the additional management that includes as well where we'll do a chest X-ray to the patient to see the correct level of the placement of the ETT, connection of the ventilator machine, as I said it before. After the intubation, will be, for instance, we'll connect the machine. After the ventilation, for instance, we check the machine is okay. We disconnect from it, and then we let the machine to ventilate by itself. Just an example, for instance, if this machine in a ventilation setting, this machine will help the patient to ventilate by himself, or the machine help it. Then the thorough blood investigation, as usual, if cases like emergency, we don't know what's the history, we have to take all those necessary blood products so that we know what is going on to the patient. Why is patient deteriorating? Why is patient unable to ventilate, unable to protect the airway? And another one, after that, the last one will be the transferring of patient for tertiary treatment. Tertiary, it means that includes with involving operating theater. Patient went to ICU or intensive care unit for further management. And in summary, few key points that we need to take in this practical session for all of us. It's important to have teamwork. When we do this, we know what's our role. As I said before, one person to give the drugs, one person as a runner, and one person as an assistant for us for every protection. Another one, as always, is the team leader. It can be a nurses, it can be a medical assistant, and it can be a doctor. As usual, the doctor will always take part in this, but as a medical assistant, just in case, where certain places, certain department where the lack of doctors are being seen there, the medical assistant will take part in doing this thing as a team leader. Okay? Then it's important to have preparation, as I said before, resuscitative equipment. Make sure that we have everything that we needed for these cases, if for instance in times of need. And the third one, it's important to know about the potential side effect. For instance, when we give the drug, we must know what are we giving. Is it safe to the patient? Is patient allergy or not? And what kind of necessary steps that we can take to prevent any of those cases that can cause a complication to the patient. We must know all of this. As a medical staff, it is crucial. And in side notes, in all this practical session, with appropriate collaborative teamwork as us, vigilant monitoring and open communication, being appropriate medication for endotracheal administration, if we provide all this, we can successfully help the patient achieve better outcome.